manage it very well secondarily. So if you continue to dress this wound, only that it may take a longer time, but it will heal. Once we make that atmosphere very conducive for healing, it's going to progress to healing. But once we get the bed to be clean enough, which is the beginning of healing, the wound will not heal if you have so much problem within the bed. But if you are able to get the bed to be clean enough to start the process of healing, then it may be ready for any other surgical intervention for cover the skill to do it, or we have the resources to do it. Um, Making the use of dry dressing, powder dressing, is one of those things that is also discouraged. I mentioned, we talked about the issue of moisture imbalance. What powder dressing would do is to cause dryness in the wound. And then what we talked about initially is that there has to be some subtle moisture balance, not imbalance now, balance, to allow epithelial cells from the edge of the wound to migrate towards the center of the wound until there is a full closure. But if we restrict that migration, yes, a lot of things that we do, the wound may still heal eventually, but only that it will take a longer period. But our goal as physician is to make sure that the wound heal as fast as possible. If need be, provide surgical intervention. But if you continue to do something that will limit that rate of growth, and those are things that have been discouraged, powder dressing may be discouraged because they make the wound dry, and then they don't allow epithelial cells to migrate as fast as they should do. Do some wounds never heal? Some wounds, will they never heal? The answer is no. All wounds should heal. All wounds should heal. Now, the things to do is what we have gone through. Identify the problem, take care of the problem. Once these two are done, that wound will heal. Identify the problem and take care of the problem. Systemic problem, identify it, take care of it. Local issues, identify it and take care of it. There is no wound that will not heal. The use of normal saline for dressings. I didn't get this question very well, but normal saline is a basic requirement for wound cleansing. So the first thing that we need to clean a wound, you debride it, you need to clean it, or you want to start dressing, you clean that wound to remove the microorganism or discharges from the wound and apply another dressing agent for another round of event. So we need to clean the wound with normal saline. Normal saline is readily available. Sterile water can also be used. Some other cleansing agents are also available for use. Serum protein, ABI. Now, it depends on what we are thinking as a cause of chronicity. That forms the decision of the investigation that we'll ask for. If we are thinking of patient having malnutrition, then patient will need to get a serum protein assessed. If it is low, then we'll continue to manage it and then repeat it until we have a normal result. The same thing with ABI is when you are thinking of arterial disease as a pathology of the chronic wound, then we need to assess the level or the severity of occlusion by doing the ABI. Now, the use of honey on exposed bone. Yes, I said honey is discouraged on exposed vital structures because honey is a very good debriding agent. At the same time, you can take care of infection, but some subtle thing that it does, and in a way it does its debridement, is that it attracts fluid from within the bed of the wound to itself and the gauze, such that it then creates some moisture around the wound. Now, if there are necrotic tissue within that bed, it becomes soft until it's able to come out. That's the way it works. Now, because it draws fluid from within the tissue, if you then put it on exposed tendon or bone, the same thing is going to happen to that tendon. It's going to continue to pull out fluid from the tendon, pull out fluid from the bone. And what happens is that it's going to become desiccated. So the surrounding area gets the benefit, but those structures, it then becomes a disadvantage for them. So it becomes desiccated, which is not what we want to do. But if you have exposed stuffs like that, what you should do is provide something that can provide moisture to them. Now, there are situations where, not just like I said, you may need to combine a lot of things. Now, you have some side of the wound that has necrotic tissue, which you want to debride. You have this exposed bone somewhere in the center of the wound, which you want to provide moisture imbalance to. You could do multiple dressing agents. So that means on those area of exposed structure, just prescribe a saline soap gauze on that area. And then the other area can get whatever dressing agent that you want to prescribe. But the nurses must be well instructed on how to do that or what you want them to do appropriately, so that they don't mix up this dressing agent. But that can also be done. Okay. So local foods. Well, there is really no special local food that helps with healing. Proteinous food generally helps with formation of granulation tissue, because all these things are from protein. So we can increase the proteinous intake of our patient generally. So maybe that may help, but there's really no special food. Patients should ideally eat healthy, all right, which will also include those proteinous food and any local diet that we have as an healthy food. And I think we have a lot around here. Uremia is also a cause of chronicity. That's also like under the contributing factor to chronicity. There are so many other ones. In fact, jaundice can also cause a delay in wound healing. The same principle applies. Take care of the primary problem, the wound will heal. Whatever that is causing uremia, we'll take care. Most likely a chronic renal failure, we'll take care of it. If patient needs to be on dialysis, let the patient be on regular dialysis. The system becomes normal, wound will heal. If patient needs to have a renal transplant eventually, just let the general system be okay, and then the wound will heal. Place of TT. Yes, if there is a wound and we are not too sure of the immune status of the patient, yes, we can offer the patient TT. So that is not out of place, but we need to assess the the immunization status of the patient before we proceed into giving the TT. Is there any question that I left behind I didn't address? Okay, thank you very much.
Hydrogen peroxide.
Oh, okay. All right, yes, thank you. Okay, yes, there are two more questions on hydrogen peroxide and okay. Now, well, the way the question is framed, is it out of place completely, or there are specific situations where we can use it? Now, I will not say it's out of place completely. That is for hydrogen peroxide. But for Uzor is now known to should be out of place completely. I'm aware a lot of people still use it, but the use is that it injures microcells, which are something that we are also expecting to come out from the wound. Well, it now depends on the balance between the rate of regeneration and the rate at which the user is affecting the cell. Whichever wins determines the progress of the wound. If more new cells are formed. Izole is not killing them, then wound healing will continue, although it's going to be slow. But hydrogen peroxide still has some role, particularly in situations where the wound is really, really very, has a lot of necrotic tissue and smelling and septic. Yes, hydrogen peroxide may be able to take care of some of those microorganisms. Now, in this instance now, then we then have to weigh. There are some wounds that are really, really, unfortunately, I didn't have an image, that are really, really very septic. Microorganisms very florid. Hydrogen peroxide or oxygen generally or hydrogen, is either hydrogen peroxide, is a very good agent that kills those microorganisms. So they may be used maybe for a short period of time to ensure that the smells go down, those burden of infection reduces, and then we can stop it by the time we think it may be affecting the normal cell at that point. Diabetic foot, is there any special treatment? The principle remains the same thing. Take care of diabetes and take care of the wound. All right, not no special attention. Take care of the, ensure that there is a good sugar control, and then take care of the local wound. But a bit of problem in is that you may not be able to sort out the issue of glucose control because of that foot that is there. No matter how hard you try, I don't know if anybody has found themselves in that situation. That you just discover that the sugar, you are happy it goes down today, tomorrow is up again, next morning it goes down. Now this occur, the wound is really very septic. So in that instance, then you need to focus on the wound first. Debulk any necrotic tissue, reduce infection as much as possible, and then you discover that your treatment for glucose then continues to become optimal, and then you can then return